morning, everyone. The idea is of this course and the way we've organized this first session is to try to talk about different perspectives and why each of us should consider the possibility of using hyperfractionation in our clinics. We are going to talk about one of the most important perspectives, which is the perspective of patients. For patients, when we have access to a treatment or when they have access to radiotherapy, we don't only consider their health and their disease. In this case, the adversity of facing oncologic pathology, but there are also costs, economical costs that are important. And from the patient's perspective, there are some direct costs, some indirect costs, and some aspects related to the quality of the life of the patient, which could imply transportation and family companionship. So direct costs are all those that are related directly with healthcare or are not related with healthcare, but will be caused by this situation. And there are other costs. Within those direct costs, we will have all treatment costs, imaging, rehab, and there will be some costs that are needed in order to have access to health service, such as transportation that could be on a bicycle, on a bus, or in a car. And that has a cost, the cost of transportation to arrive to the health center. And there's also a cost. If I'm in a car, I will have to pay for the parking lot for X amount of time. So patients need to pay these in order to have access to the health service, although they're not part of the healthcare service. There are other indirect costs, which is the loss of productivity. A patient that cannot go to work, that it would be one day of their life dedicated to healthcare, is going to make the patient to not generate an income, will lose productivity. So there will be a load for the individuals, for the family, and for the employer. So this, here we have a table where there are multiple costs that are direct and direct and indirect. And all these costs must be important. And we must consider them at the time of prescribing a treatment. I don't want to, it's not that this is the most important thing, but this is an element where we will need to seek that that treatment that we are offering our patients should be accessible, and the patient should consider also the toxicity of health costs. When we talk and we add one after the other, the costs that we've been talking about, patients could have a risk, they and their families, that part of their family patrimony, that what they've built during their lifetime is at risk. And we're talking about patients that are not only going to have radiotherapy, they'll have other treatments, and all these could cause economical risks for them and their families, generating an important emotional burden. And nobody wants patients to have a poor quality of life because it would affect the survival of the patients. They won't be emotionally ready to have access to all treatments, and they will have to, not do some of the treatments. So radiotherapy is a course for patients that are at home that need to take some way of transportation to go to radiotherapy, and then they need to go home. But while the patients go from home to the radiotherapy center, many things will happen. There's transportation, there are waiting times, interactions, iterations, because the patients sometimes have to wait for long times, and there's feeding costs that are not in the visual budget of patients. So let's place this into a perspective, the cost, how we as oncologists could impact the cost. I'm going to use an example, the example of Colombia. In this particular case, we have many participants from different countries. So each country might have the different characteristics in the system, but this might be an interesting example for those in Latin America. In Colombia, direct costs of healthcare are paid 100% by the Colombian health system. Patients should not pay for treatment. Insurance in Colombia is close to 98%. 98% of the population in Colombia is affiliated to a solidarity health system, which has a figure. These are some companies that manage healthcare, and they are the ones who are going to pay the direct cost of treatment. There are some costs that are direct, that are not associated to health. If the coverage of our system in Colombia is very good, patients can have difficulties to have access for treatment, and they can need a legal consultancy or help to have access to the system. There are transportation costs, parking lot payments, free food payments. So all of those who are here connected on a Saturday, and we're mostly oncologist physicians, we have an impact of, do we have an impact on all these patients, and what would be the impact of our decisions? Let me share some examples so we can analyze which could be the impact of these decisions. We have a patient, Marisol, 42 years old. She has breast cancer, early stage breast cancer. And in this case, Marisol was taken to a radio sentinel, and Marisol works at a restaurant. She is a waiter. She receives 30,000 pesos a day. In dollars, it means like $6 per hour. She gets like $5 more on $6 a day, $5 on tips, and she works with a figure where she's going to get paid for 8 hours a day, 70,000 pesos. Why should we consider the patient and her family? Because Marisol was seen by ex-doctor, and he ordered radiotherapy and RP to the breast with 50 grays in 25 fractions, and then reinforcement of 10 grays in 5 fractions. So what are the direct costs not associated in health for her to go there? So she needs 5,000 pesos every day. That means $1. And she also needs to have a coffee and something to eat for 30 days. So the indirect cost. So what is the opportunity cost of not going to work for Marisol? Every day she doesn't work, she is generating a cost, and she's going to go to treatment with her sister, who has to stop working to be with Marisol. That also generates an opportunity cost, not working to be with her sister. So this would be in that scenario where that patient was programmed for 30 treatment sessions. But if on the contrary, Marisol would receive a treatment of hypofractioning with a fast forward, she would have 5 sessions. And what we would see is, look at the difference in the total cost. That would be 2,002,000 pesos. If it would be just 5 sessions, it would be, the net difference would be a difference in dollars of around $500 just for the decision of the different treatment type. Another example is a patient called Pedro. Pedro is a 68-year-old patient with a diagnosis of prostatic cancer. He doesn't want surgery, he wants radiotherapy. And in this case, Pedro was programmed for conventional radiotherapy, 76 grays in 38 fractions, and a hormone blockage. And he was retired 7 years ago, which is good. He gets his retirement money, but he takes care of his 3-year-old grandson every day. So let's look at the cost of Pedro not taking care of his grandson during those 38 sessions. We're talking about direct costs. Besides that, direct costs that are those of transportation. So since he cannot go to take care of his grandson, he needs to pay for someone to take care of his grandchild. And this will be a percentage that every month that he would be in treatment, he will be 2 months in treatment, the costs, the direct cost associated to health are 45% of his retirement money. On the contrary, if that patient, same Pedro, was programmed with a with hypofractionated therapy, 60 grays in 20 fractions, we're talking about a net difference of around $150 a month that Pedro could be saving. So if patients have a clinical situation, it is important to know that hypofractioning is a treatment standard in multiple pathologies, and we should all know them, and that we should try to offer our patients the most possible efficient treatment. Efficiency has two definitions. One is that the efficiency in cancer is being able to offer a treatment focused on the outcomes patient is concerned. He are concerned about, of course, healing, also about the quality of life associated to the quality of life of patients. And we have the other definition of efficiency is that we must try to generate health value, which is the outcome, the cost that we're generating, not only the treatment, but and the ones associated to health at the end, the one that give us most value for the treatment, that will be the most efficient, is the one generated by the outcome as the multiple pathologies that we will see during the course, that at the end will have a lower cost for society. So in Colombia, the payment is done by an insurance. So that insurance should consider that it has a direct cost associated to health, which is the treatment per se, but also cost non-associated to health. In this case, those insurance companies must pay transportation to go to treatment. So this is a graph of Colombia, and there's a concentration. So as you can see, half of the states in Colombia only have one radiotherapy center closed, and there's large areas in Colombia with far away radiotherapy centers, so the health centers need to pay to the patients. So if treatment is shorter and lasts less, we are benefiting also the health companies because patients will spend less time outside of their home area. So it's going to habilitate the capacity of the centers for treatment also, because if I have very few treatments, head center for do treatments. If I have shorter treatment times, then it will also benefit the centers. So for me, it has been a pleasure to share this session with you today, and Benjamin will continue. Thank you, Alejo. If you have questions about Pedro, if you have questions, please write them out in the chat. I am Benjamin, and I would like us to do, first of all, ask you some questions. We need to put on the face of the administrator. And and it has different effects for the clinics depending on the circumstances. So, okay, so when we're implementing hypofractionation, choose one. The same effect on the clinic, operation across all scenarios, different effects for clinics depending on the circumstances, or random effects on clinics and should not be trusted. So you have the poll on your question, on your screen. So please write down your answer. The answers are anonymous, and then we will discuss the right answer. Thank you, Maria, for opening the poll. And I can see the questions. We have 300. Let's wait a couple of more seconds.
Vamos a 400. Yo les dejo 5 segundos más.
Okay, 5 more seconds. 3, 2, 1. And we are going to share the results. So now you can see that around 75% said B and 25% A. And 9 people chose C. Good. The right answer is B. And I'm going to show you why there are certain important factors that must be considered that affect hypofractioning at the clinic. Hypofractioning can include the clinic depending of the circumstances of the clinic. It could decrease the internal cost per patient, or it could increase or decrease the time for staff. This is a very important point because we have to think about if I do have enough staff for hypofractionation, and it can also improve the clinic's revenues. This is a graph of a paper called Kendall.
Expand global radiotherapy access.
This paper, it's on you can see the name of the paper on the bottom, and they compared 25 versus 20 and 39 versus 20 fractions. And it's obvious that the operational costs in the clinic are lower when we decrease the number of fractions. But there are more details. If the clinic is beyond the total capacity, for example, they have a wait line for patients, hyperfractioning can increase the patient's throughput, the number of patients that are seen, and also increase the revenues. Nevertheless, when we are seeing more patients, we need to make more simulations, we have to make more planifications, and this will require the dedication of the whole staff. More consultations. If the clinic is working beyond its capacity. On the other hand, if the clinic is under capacity, they don't have a waiting line, hypofractioning can decrease the staff hours needed for patient care. There would be less treatment visits, less configurations and treatments, less check-ins, and the same or more amount of patient-specific QA. So please think, your clinic is past full capacity or under capacity. And why is this important? Why is this question important? If I am in a large clinic and this is makes a greater absolute difference because each difference is multiplied by patient, the adoption of hypofractionation protocols can have a big impact in the profits and access of patients to care within the region, right? For small clinics, it could free up valuable staff time if the staff is not as busy doing so many things because treatments are shorter. It gives them more time to focus in the quality of each treatment, in the clinical development, in the development of projects in order to improve the clinic's efficiency. So that's also very valuable. And now we are going to make model simulations. We're going to make a model considering the demographics of the patient, the fractioning patterns that are projected, calculate the clinic capacities, the costs, as well as the revenues. And there are two ways that we can do this. We can make a simple model with fixed treatment slots, or a complex model with average distribution. And that's closer to real life. So let's begin with a simple model. And I'm going to show you the difference comparing one scenario with conventional. And I am at my clinic. I have a team, and I'm looking at the list of patients I'm gonna treat. There are fixed slots, and there's people with early breast cancer that will take 3 weeks each person for 15 fractionations. And after 6 months, or 6 months, I will have 8.6 patients. For post-mastectomy breast cancer patients, it's going to be 5 weeks, 25 fractions, prostate, 7 weeks, etc. And in the different pathologies have different time needs. And if I add that total, you can find it here. This is fractionation versus hypofractionation. So it's just going to be 1 week for each treatment. So I can treat 26 patients after 6 months. For intermediate risk prostate cancer, I'm doing SBRP, 1 week of treatment, etc. Rectal cancer, short course, and prostate high risk prostate cancer with moderate hyperfractionation. And if we compare, we can see that we can have many more patients, but this isn't how it works in the real life. It's a useful start, but let's look at the complex model with the averaged distribution that's more similar to the real life. We have to consider the distribution of patients. In the model, always use 10% for each pathology and 40% for other types of cancers. And that model uses one linear accelerator that operates 12 hours a day, treating 4 patients per hour. We have the number of fractions used today and hyperfractioning that's projected. And there's a form that we can use in order to calculate the number of treated patients per year, the number of devices, the number of fractions delivered per machine per year, and the average of number of fractions delivered per patient. Each linear accelerator has a certain number of slots for treatment every day. These all filled with patients until the slots are full, one at a time. So I am placing my patients here. Please recall, I have 10%, red, 10%. Okay, here I had red, orange, and after filling all the slots up, I am at 39 patients with conventional fractioning. If I do the same thing with hypofractioning, that's how we do it in the real, this is how we do it in the real life. We have 64 patients at the end, 37 versus 64. And the clinics, an important assumption in this model is that the clinic has a waiting list that is limitless, and that's also the average distribution. And in 1 year, if our average was 24 fractions per patient, we were able to arrive to 510 patients per year, and with hypofractioning, according to our distribution of our average per patient was 14.5, and we treated 860 patients. So this is a model that you can use and to calculate. And this is something I recommend to the managers of all these clinics that are thinking about adopting hypofractioning, that they should do. So comparing those two numbers, we have 350 patients more, 350 more patients treated per year, treating 4 patients per hour. I know that in Latam, the burden can be larger and we have more than one team. So we are having more patients treated per year, and considering the 4 hours of work per patient for 4 patients by the physician and the medical physician, that means it's going to be more work because it will be more shifts, more planning. These will require around 1,400 hours of work. And this is like a salary of $45 per hour. Then that means it's 63,000 more dollars in the payment of for these professionals, but these costs are compensated with additional income and the distribution of the cost per patient. So it's worthwhile, but we need to invest in human resources. Thank you very much, and I am here to answer any questions you might have. It's turn. Thank you, Ben. Please recall that you can ask your questions in the chat. We've had several comments. Thanks for all who have shared comments of their experiences of radiotherapy in the different countries of LATAM. So we invite you to send your questions so we can learn about the situations of the different countries. Good morning, everyone. Thanks for being today here with us. We are really excited for this course. So starting with the global perspective, for several years, we've been working with the International Agency of Atomic Energy to understand which are the gaps we have in our region about radiotherapy and how we should start to project investment projects and generation of human resources to close these gaps, give better treatment to our patients. And definitely this is related with education. And this is the reason to be of our organization of Race Against Cancer. To begin with, it's important to understand where are we. We know that for 2020, around 21% of the total cancer load in Latin America, 21% of the load, we have 21% of the world load, and this is going to be 32% around 2030. But the installed capacity in terms of machines only represents 10% of the number of total machines in the world. So after understanding a little bit this panorama, we start to check all this installed capacity in terms of human resources, machinery resources, to see how we can project the implementation in the future. So Latin America has around 561 clinics, 798 lineal accelerators. Still, we have some cobots that are installed and around 298 brachytherapy machines. For example, 30% of the clinics only have brachytherapy, and we know that this is a very important resource. When we talk about staff resource, like Bentley and Alejo mentioned, it is important to note that as we use high technology, we will have additional activities where we are going to require more staff in order to comply with the burden, the work burden or workload. So we talk about technology in Latin America. We know that technology in external radiotherapy is divided at 4 main levels, and high technology understood as level 1 or 2, where we're going to have cone beam, portal dosimetry, robotic tables, etc., etc. But without with no association with any specific brand, we are going to look at the classification according to the levels, with each machine within the levels. So the most concerning part is that right now, around 13% of the installed capacity in our region is of level 1 and level 2 machines, okay? So an example, and Alejo already mentioned in the chat, Colombia has grown in the last 2 years at 32% in technology. So we can see that making all these problematic visible shows that we have more machines, and that investors started to understand what needs to be done in order to solve the issue of cancer in our region. Another important point, all this data has been published during the last 2 years with the group. And if we project the whole installed capacity that we have right now in LATAM, we see that in 10 years, right now we have 66% of obsolescence, and in 10 years, it would be 100% of obsolescence of the installed capacity. Why is this important? Well, because we need to make the managers, the management of our hospitals, to understand that when we are generating a business case, they need to understand how long it takes for a machine to depreciate. A brachytherapy takes 10 to 15 years, but a brachytherapy applicator, it just takes 3 years. So this is very important to note, because, and then we need to talk with the administration in order to implement everything at our centers. So when we calculate, you will find the Excel that we use for the calculations is going to found In the papers I already showed you, they're all available for free. You can download these supplementary material and you can make your own exercise for your own clinics, your institutions, your countries, your regions. So when we evaluate a case for Colombia, assuming that for install accelerator, we take care of 100 patients per day with 25 fractions per patient. In 2020, we have a deficit of machines of 28 machines, and in 2030, it will go up to 39 machines. If you look at the map, what Alejandro showed in the Amazonian and the Orinoquia, half of the country doesn't have radiotherapy install capacity. So there is a unbalance in the access. If we start to implement hypofractioning, we see that only reducing to 20 fractions in average, the install capacity or the gap that's necessary to have optimal treatment will reduce to half or even more. So please look at the impact, the fact that we do hypofractioning in our clinics. So when we started to see the real use of hypofractioning globally, this was a survey that was published in 2021, and LATAM had an important representation with 286 answers for this survey. So we can see that when we look at the main indications that we will talk about in depth in the next lectures within the course, hypofractioning, conservation surgeries, there's a use range of 78%, but towards mastectomy with positive or negative nodes, well, the percentage of use is reduced even though we have available evidence that we can do it in these type of scenarios. In prostate cancer, it's even greater. We have use of less than 45% for low, intermediate, and high risk, even in pelvic irradiation, when we have enough evidence right now by prescription in the guidelines that the use of hyperfractioning is a gold standard for this pathology. For palliative treatment, we still don't have much to discuss because we all do use it in this scenario. In cervix cancer, well, for cervix cancer, this is a global issue and greater for our region. If we see cervix cancer, the use of hyperfractioning is very poor. We have treatment results of treatments done at India mainly, and in our region, there is a protocol in Mexico and a protocol in Bolivia that are in process to argument the use of these treatment, this pathology, and we know in radiobiological terms that for cervix cancer, it's highly needed. For bone metastases, we don't have any inconvenience in the use of this type of treatment. But the most important thing when we analyze why we are looking as clinicians in order to start to use some technology, well, the clinical evidence has it has a very important role, and these uses have clinical equivalence like 71% of local use. Look at the bottom, the graph is very loaded. I just wanted to point out or focus in the main points that are under the barriers. And it is important to see that the fact of optimizing the research and generating more availability of machines, because we have a large gap in the installed capacity, and the fact of reducing costs is also important for us. And additionally, the barriers of access are also associated of, as we don't have results in the long term of implementation of radiofractioning, or the fear of the probability of acute or late results. So if we segment or by geographical localization, we see that for LATAM, the technological barrier, the fact of not having the ideal technology for this treatment is an implementation barrier, contrary from the United States, where only 3.2% gave this answer. To think about reimbursement, many countries, each country has its individual characteristics. In Colombia, for example, we have bundle payment or a bundle payment, while in other countries, as Mexico and Peru, there are fraction payments. And in the rest of the countries, there are differentiations in the type of reimbursements for these treatments. So what are predictors for the use of hypofractioning? The fact of living in the US, in a country with a high income country with high technology, the fact of having an affiliation to the university, of having university practices where they're always at the state of the art with the different processes, also having an influence area, that the center has an influence area where they can capture a large population, and the use of IMRT for these patients. When we talk in a region, both in Asia Pacific, Latin America, low income countries, well, the fact of being with these indications, we see that this is a barrier, so patients can implement hypofractioning in the different indications. So this is a study that we did with a group published recently about the first curriculum we did as a pilot in Colombia. And one of the main implementation barriers for hypofractioning is the educational barrier. And that's why we're here today, to generate awareness, educate about the different indications and results that we can obtain with our treatments. Also, we see that there is heterogeneity of formation in Latin America. And in fact, this is global. It's not just an issue of Latin America about the training of our radio oncologists. In Latin America, annually, we graduate 125 radio oncologists. 56% are produced by Brazil, and the rest in the different countries. And you can see that the access to high technology for their education is around 56 to 60% of the treatments done. They are done with high technology. And access to radiosurgery is less than 50%. And access to brachytherapy, training in brachytherapy, well, they are not being trained enough. So we need to map the existing residencies, understand where we have these batches in order to know where we can impact. So when we talk about the challenges, the critical challenges in hypofractioning or in cancer treatment, we know that the volume of patients with cancer worldwide is increasing. When we look at it from the perspective of the patient as a consumer of our resources, of our treatments, we see that the patient has more and more options, has high expectations about outcomes and of having a better experience. And that's why we are all advocated to build services with attention center in the patient. And it is important to also to understand the reimbursement topic, the cost, numbers, standards are evolving. Payers are trying to decrease that payment for treatment working in a cohesive manner from the clinical perspective and with the administrators to generate cases where we can all do better treatments and to be convenient for all. So the fact that for us to do hypofractioning with high technology, well, then if we do that, we'll be more precise, we'll do greater doses with less amount of fractions, we're going to be faster, and the total treatment time is going to be shorter. We'll be able to treat more patients with the described installed capacity that has been proved, and we will be able to reduce treatment costs, some variables of the treatment cost. So when we look at hyperfractionation with high quality treatments being very cost effective, if we look at the perspective of the supplier, we will be able to treat more patients. The fact of us doing less treatments per patient will increase that capacity, and we will be able to improve the volume of patients that we are going to treat, reducing the cost of care, as Alejandro showed in the beginning. And from the perspective of the patient, we see that additionally, it's going to reduce the indirect costs that Alejandro also showed about the probability that patients will interrupt their treatments. They will have to spend less pocket money. We can take them back to their daily life as soon as possible, and to have a positive impact in their life quality of life, as we mentioned previously, even generating less adverse effects on the long and short term. So we see which are the clinical challenges that we have within our region. It is important to know which are the needs of equipment and workforce. We need to understand how to deliver a conformal dose to each type of tumor. We must ensure a clinical course or a workflow as smooth as possible, understanding that we are a work team, including the physician, the medical physical physician. We need to plan for the future to narrow the gaps that we've seen in the previous slides. And key is the key to success. So that's why we're here today. So from the global perspective, we know that there's a huge gap in the number of machines globally and in Latin America, as I showed before. As standard, we should have one machine per 500, 600 treated patients. And the fact that we do hypofractionation, we can increase the number of patients to around 800 patients per year per machine. So understand all these will improve the resources that we will be able to offer to our patients without compromising the care, without compromising the quality of the care. We're going to cure with good quality of life, which is very important, and that's our reason to be as well. So as final message, hyperfractioning requires high technical skill and time, but this course will help us somehow to understand all the specific nuances that we require to give an optimal treatment to our patients. In behalf of the whole organization, thank you for being today with us, and we are open to questions. This is the bibliography that we're going to share in the drive that we're going to share. It's going to be available so you can check it, and we're open to answer any doubt or question you have. Next session is going to be in 1 week. It's going to be about radiobiology of hypofractionation. I'm going to stop sharing so we can start the Q&A session. Thank you, David, Alejandro, and Benjamin, for your excellent presentations. I believe that there are many comments and doubts in the chat, about the different experiences within Latin America. So right now, we invite you, if you have questions, please raise your hand and ask them. One of the last questions I see in the chat, I feel is something that was generalized in the chat, that balance between making a shorter treatment, but how should the training of the staff, of the physicians, the use of new technologies like IGRT and MRT, because there's a group of questions in the chat related to the centers that still don't have this type of technologies. So I don't know if you would like to share with us, what do you think about this balance between implementing new techniques that allow us to reduce the treatment time of patients that we know that has many advantages for the Latin America centers that have few linear accelerators, and how to manage or look for these balance. So I give you the floor, and please keep sending your questions or raise your hands if you want to participate. Thank you, Maria. I just want to share a couple of words. If we want to improve, we need to change. Improvement is not a passive process, it's an active process. So just think about that. And for some centers, it means that they have to invest in courses. But I give the floor to David and Alejo to discuss this topic. Thank you, Ben. Well, I would like to say that in the poll and in the scenario that we saw, is the impact of radio fractioning could depend of each center. And as Ben and David shared, each center should quantify its capacity, the number of physicians, its treatment objective. Because first, to do hypofractioning has advantages for the patient. It has clinical evidence, but also the services can be more dynamic, but they're not illimited. The availability that we have is not illimited. There's a limit that will depend on the amount, how many physicians there's in a center, how many physical, the infrastructure of each center. Each center must make an analysis and know its capacity, and if they're going to implement hypofractioning, depending on the pathologies that are more prevalent in their center, how they can implement this. So the idea of the course is incentivize the use of hypofractionation because it has some advantages, as we showed you, from the perspective of the logistics, but also it has to be done with being sure that the implementation will be used for the pathologies where there is evidence following. So there's someone asked about the technology, and there could be hypofractioning techniques that can be used with lower technology and others that will require more technology. And the treatment time of as physicians is fundamental because we need to do some planning for these patients, and it's going to be the same time and needs to be measured in order to provide good services with a good quality, because we need to ensure the quality of our treatments, first of all. Thank you, Alejo. Totally agree with what you just mentioned. We have to have something important here is the topic of the clinical work. We require that technology for the implementation in the different pathologies. And we're going to talk about this extensively in the following sessions. And we will be able to talk about the specifications for each treatment. It is important for us to do the exercise and work with the management in order to be able to do activity rate driven cost activities to see how much I spend per minute, how many oncologists I need, like a surgeon, how many surgeries did you do? Okay, start doing all these statistics. But many times, many of these managers, for them, it's very clear that the processes that we have implicit within a treatment time for a new patient, this is clear for them. So based on that, we need to calculate the human resources depending of how we are doing our treatments. Within the papers that we will share with you, as I mentioned, in the material that we're going to share, we have a calculator that will help you all to start to generate specific calculations about these needs, okay? Both of human resource and machinery to check, to make a model of the treatments that you can do, and so you can start visualizing what you require and what you're going to be able to do. Now I'll give the floor to Dr. Federico Maldonado, who raised his hand and that additionally for the whole session shared interesting information about radiotherapy in Mexico. So Dr. Federico, please open your mic. Okay, two comments. I think that for the implementation of hypofractionation, we start with the safety of the patient, always without risking our patients. And unfortunately, I don't know what is the situation of the countries of Latin America, but here in Mexico, we have a very big issue between public and private assistance. To talk about hyperfractioning, we have to have technology, so the quality control of each treatment should be optimal and adequate. Unfortunately, here privately, the centers have devices and safety for patients, but in public centers, we are full of patients in our radiotherapy services. We need to implement quality control. That would be the challenge. We have long waiting list times. In some places, the machines, I think we all have the issue of training the staff, training human resources. We need money for that. We also need money to upgrade our so the idea is to implement the minimum safety requirements to implement in a public care. That's my comment. Thank you. I would like to add one more thing. Many of the structures, both staff and machines, are based on the population criteria. When we calculate it per population versus calculating the use of explicit radiotherapy with the 10 most frequent pathologies for cancer treatment, there is an asymmetry in the requirement. Okay, the thing I have the most is breast cancer, so my requirement is going to be higher because I have 1 million of inhabitants. So it's important to calculate, like fine-tune the need, the specific need for each subpopulation. That's why I invite you to check in depth this paper that it took 3 years for us to publish, but could provide many tools to mention our health services within the region. Thank you, David. About what Dr. Federico mentioned, one of the strongest points of this curriculum is that will have educators from different countries of the world where the systems, the payment of radiotherapy, which was a question, that was raised. Well, in Latin America, we have bundle payment, we have payment per session. And the interesting thing is that the educators of the clinical applications also have different payment systems, so they can share their vision of how to make decisions from the point of view of the clinic, which are safe considering what they've done at their centers with the different payment methods. So I would like to add that. Let's say that this is something that's going to feed the discussions because we have those experiences of different payment methods. A comment. It's important to understand what's cost, what's price. Here, we're going into the term of cost. Cost is what I need, the money I need to invest to generate a result of an X activity. How much does it cost to have external radiotherapy fraction? And in terms of price, it's how much is the cost plus minus my revenue in a percentage. So when we are going to the insurance company in a public or private scenario, we need to warrant that we cover the cost and we have a revenue margin, including the depreciation of devices in time in order to renovate them. And somehow this is what hasn't been taught through time. And that's why we have old technology and that is so high, with such a high prevalence. We need to think in more economical terms. The structure of why we wanted to sensibilize about this is to go deeper into these topics and to be able to look at the eye to the managers and explain this. And if we know our cost, the risk of a low price, which is a very poor situation, and it's going to improve. Thank you very much. I have a question within the chat. If you know, there's a paper, a very interesting paper, how to expand access to radiotherapy worldwide. And one of the things that also that's in the debate is to it's very costly to start a radiotherapy center. One of the question is, do you have a vision of what is really that cost compared to chemotherapy? And we have more target therapy, immunotherapy that are also very expensive instead of investing more in radiotherapy. So that's one of the questions. When we analyze the three main pillars of cancer treatment cure, which are surgery, radiotherapy, and chemotherapy. These are the three pillars. Surgery is 49%, curing patients. Radiation
solamente un 11%. Todo esto se los...
And chemo only 11%. I'm writing this in the chat because there is literature that supports all these. Nevertheless, we know that the highest cost is for chemotherapy. But definitely when we see cases or business cases like Finland, Norway, England, where the costs are well studied, we see that the investment in radiotherapy compared to a treatment of a patient with cancer represents only 5% of cost, radiation, 5%. The impact compared to the impact. So that's why radiotherapy is the most cost-effective therapy. So when we invest initially to start a radiotherapy center, quotes, that investment could be important. Nevertheless, when it's compared against the expense, for example, in immunotherapy per year, the expense of one patient allows me to start a brachytherapy center per year. So look at the difference in terms of financial toxicity, as Alejandro mentioned. So that's why it's important for us to understand, quotes, power of what we do and that radiation cures. Recently, I was in an interview and I told the journalist, I challenge you to look into Google chemotherapy and you find cure, good things. If you look at radiotherapy, it's toxicity. That's the speech that we need to start to reverse. Radiotherapy cures, highly costly effective. Any other comments? I agree, David. I would just like to add the word of efficiency in cancer, that independently of the treatment, we need to look for the most efficient for the patient, and that the definition of efficiency is based in the outcome the patient wants, is linked to what the patient, what David said. Radiotherapy has the capacity to cure patients, and we need to try to anchor and generate consciousness about the role and the importance of radiotherapy in cancer treatment. And it's anchored to the outcomes that the patients care about, and radiotherapy is very efficient for cancer treatment. Any more questions, or you want to raise your hand? There are many comments, but if you want to ask a question, please do so. There was a question from Angel. If a center only has 2D technology, has no simulation, 3D simulation, is it safe to do hypofractioning? Share your opinions. In terms of safety, if it's 2D, none. We're going to discuss later on this topic, that in the minimum technology is going to be 3D. So if you have 2D, personally, I wouldn't do it. I don't know if Alejo has any other comment. I would like to separate the topic. If I don't have the capacity to think of tomography to delimitate the volumes, probably I would agree with, well, the studies are not designed for the clinical effectiveness of the protocols in a scenario where there's no capacity to do the 3D delimitation. So if I don't have the capacity to make that verification in 3D, so if I only have D images for verification, there would be the possibility, depending on the protocol and the pathology, linked to technology. So when also saw in the chat, they were asking about what I just commented, which is the bibliography of the rate that supports the fact that radiotherapy is the most cost-effective therapy. Here, what we're saying, that it represents only 5% of the cost. All this literature, we're going to share it. Well, it's going to be on the drive, so you can check it. Thank you. So I'm going to give the floor to Dr. Fabian Correa, who raised his hand. Good morning. Thanks to all participants and organizers from Chile. My question is, within the hospital management, in order to maximize the use of the machines and decrease the waiting lists, we, at the beginning, when we adopted Mass Forward, we did it Monday to Friday with the great amount of patients we treat that came after the pandemic. We started on Wednesdays, Thursdays, and Fridays, and I have a doubt about how positive is this to fill the machines and that the patients would have one fraction of 5.2 gray on Friday, and then Saturday and Sunday they would rest and would start again from Monday to Thursday to finish the fractions. And also about 2D radiotherapy. With 3D, I know we have the possibility of finding literature that says, yes, you can do a fast forward using 3D. But my center, we take only 3D at the beginning, in the middle, and the end, and there are X-rays, AP, and with that, we assume that next day the patient will be good. So do you have, and what does the literature says about taking X-ray every day if you don't have a combi CT or something that gives you a portal image that's more direct? Or with those 3, is it enough? And the other 2 days that we didn't take an image, the patient maintained the parameters. Well, we must differentiate, or we should differentiate first how I planify and do the RT line. So we don't mix more things. The protocols, well, radiobiology of when we start, if we start off Wednesday or Thursday or Friday, will be answered on that lecture, because we will talk deeper into these protocols on that session and differentiating the planification versus of how I make the evaluation in the machine. So planification should have a minimum requirements, should be planification with a CT. If we do tangentials, it's another topic, but it should be 3D with tomography, and the verifications can be done with a plate, with cone beam, etc. That's a different thing. So planification technology should be directly with CT scan. I would like to add, in the fast forward protocol, they take an image, they take images with X-rays, 2D every day. That's the way the protocol was created, and my recommendation is to do this because the protocol showed equivalence with the conventional fractionation.